clinicians who are very interested in the topic of adult care and the transition, but weren't able to dial in today. And so I will record for their benefit as well as for reference later on. So we've started recording, and if I can get 1 or 2 people confirm that they received the slides through email, we can get started.
They came to me.
They came through? Okay.
Yep.
Okay. If anyone hasn't received the slides yet, let me know in chat, and I'll send, well, I'll circulate them after our call again as a PDF form, because if they're coming through as PowerPoint slides, the file attachment might be too big and be caught by your server. So I'll send them as a small PDF file, and I'll send a link to the recording.
We're able to open it at Baylor.
Oh, good, good. Thank you, Judy. Okay, so I'll save a few updates about the bigger world of Rett syndrome for the end of our call, but in the interest of time and with it being a Friday afternoon, Jane, would you like to go ahead and introduce yourself, and we'll get started on our topic?
Sure. So let me start out by saying that when Paige asked me to talk about these transitions, I was a little bit intimidated with the topic, not necessarily that I'm not comfortable from a standpoint of what we've seen and learned and about caring for the adult with Rett syndrome, but with telling physicians on the call or perceiving to tell physicians how to do it. But and I'm not by any means an expert as well on the topic of transitioning care. But I do think it's important, and so I would like to give some data about what we've learned from the natural history study and what we've learned from families, as well as introducing the topic of transitioning for discussion. And so, Paige, how do I go to my next slide? It's not.
Take page down.
Yep, I did that. Nothing. The screen is this what happened before?
You click on your slide. Have you clicked?
Okay, wait a minute. There we go. And so this is my slide. This is who I am. I think you all know me in one way or another. I'm the research nurse manager at UAB Rett Clinic, and Paige always says University of Alabama, which is a promotion in my book. We are actually the smaller school, University of Alabama at Birmingham. Lately in the news because we pulled an upset yesterday in the basketball tournament, so we are very proud to be UAB Blazers. I'm also the Rett Consortium project manager for the next go-around of the NIH Rare Disease Clinical Research Network natural history study of Rett syndrome, MECP2 duplications, and Rett-related disorders, namely CDKL5 and FOXG1 mutations. So I'll just dive right in. And so the problem, if you will, is that you are all either primary pediatricians or pediatric subspecialists or perhaps pediatric nurses, so we really are pediatricians in quotes, if you will, trying to function in an adult healthcare world often as Rett centers and Rett clinics around the country. And this is partly a good problem of our own making, as we've, I think, provided and promoted better health care that's led to a longer lifespan in girls and women with Rett syndrome. But it has posed some problems or led to some problems, and I think at best, as pediatricians caring for adults in our Rett clinics and centers, at best we are leading the transition of those adolescents who are aging out of pediatric care, and at worst, I think we are assuming the role as adult primary care physicians and caregivers, and that comes with some angst for some caregivers and physicians, and certainly angst on the other end from the transition end for families, and we'll talk more about that in a bit. So let's talk first about assuming the role of a primary care physician in your subspecialty or Rett syndrome clinics. And what I want to do in the next slide is to outline some adult health maintenance guidelines, and then after that give some updates on what we've learned from the natural history study in and of itself, but also just as clinicians having done this for a few years. Because, of course, our goal is to promote or to access great care and to promote healthy adults. The next two slides give various test schedules for adults, and I'm proud to say I got this out of Real Simple magazine. It's not anything highfalutin like, pediatric journals or whatnot. It's just what is out in the public domain and in the public media, but we don't necessarily think about how to relate these to adults with Rett syndrome. I think this largely is because parents of children with Rett syndrome are I focus on that or want to stress the word children, is that they're very involved, very anxious, either with Rett syndrome or well children. We all are very focused on annual health exams, well child visits to the pediatrician, and that seems to drop off, I think, as our children become adults. Whether you're tired or you just think everything's coasting along, I've done everything I could for the first 18 years and I can kind of coast along. And so I think that we have to promote this continuation of health and health maintenance as in our roles as often the primary caregivers for these adults that are coming to our clinics. I've asterished a couple of tests on this first slide of health test calendar or schedule, and one, the first one that's highlighted is cholesterol screening, and I highlight this because there's been some discussion on the Facebook pages about cholesterol levels being elevated, and some anecdotal reports from different centers across the Rett centers across the states about identifying some elevations in cholesterol screening that not everybody appreciates, but that certainly is enough of a trend that it at least bears a discussion. And whether or not this is because of environmental issues such as pushing diets that are not necessarily healthy for cholesterol or cardiovascular reasons, but certainly have promoted or advanced weight gain, which many of the families battle, and we battle along with them. And so our attitudes have been, in the past here at least, to let's get the weight on and then worry about what we've done to cardiovascular health or cholesterol levels or lipid levels later on. And I'm not going to read each line of this, but you certainly can feel comfortable using it as a tool if you're asked about some of these things in your clinics. The second test on this screen that is highlighted is the bone density test, and we all understand the significance of bone density in girl and woman with Rett syndrome, partly because of ambulation or standing difficulties, often problems associated with poor calcium or milk intake. Paige, did you see that message that the audio may be going in and out?
I just thought I can hear fine. If some other people can let me know on chat if your audio is going in and out, I'll see what I can do. Yeah, I hear you okay.
Okay. And so, and then of course, anti-epileptic medications can have a negative effect on bone density. And while a DEXA may make it maybe a difficult test for an individual with Rett syndrome to tolerate in terms of being, the necessity of lying still, there are certainly ways to get around that, or other tests that could be done to measure and assess bone density. The frequency, let me say this, that the frequencies that are listed here are in the typical population and are not necessarily ones for Rett syndrome or would apply to Rett syndrome, but they are ones to modify as you see fit. But I thought it would be interesting to see exactly what is recommended for the general population, because we shouldn't approach health care and health maintenance any differently for the children we follow and women that we follow in clinic just because they have a developmental disorder. The second page of this test calendar continues with the typical tests for our health maintenance issues that we probably all are in one way or another familiar with from our own health care. Although there's not an asterisk for mammogram, it is something that I talk about when I give my talks to parents about their daughters who are maturing. I don't know of any woman with Rett syndrome who has undergone a mammogram. It's certainly not something I look forward to, but it's a necessary when you can understand the test itself, it's certainly a necessary one to consider. But while you may not recommend to families that mammograms occur for their daughters, there's certainly other ways, such as a breast exam, not a self-exam, but a hands-on breast exam that can be done monthly and pick up changes, and as well as striving for that close examination to make sure that everything is healthy. And this may be even more necessary for those women that are in long-term facilities who may not get that close look that a mother or father might do. The second one on this schedule, Pap smear, is also something that is very controversial, or at least cause for discussion as to whether it's even necessary in a non-sexually active person. And so I would say at the very least it's a conundrum amongst healthcare professionals. On one regard, it's the equal rights protection that all individuals should be treated equally. That's certainly the position that the American College of Obstetrics and Gynecology takes. They don't distinguish between the care of those with and without developmental delays. But then, of course, there's the other side of the table that says that it's better approached with a practical application, that it might not necessarily be, or it might not be necessary in someone who's not sexually active unless there is a problem. And so you would hope that that would be someone being very attuned to change in behavior that might suggest that there's pain, or if there's unusual bleeding, or unfortunately abuse. And I bring up abuse because we don't we focus in pediatric world with sexual abuse being an unfortunate and a horrible situation that affects children, but in fact, adults with developmental disabilities are many times more likely to be abused than other adults. And this is, although the reference to this fact didn't make it onto the slide, it's actually quoting some information from Dick Sobsey, which is an individual active in our MECP2 duplication community. Dick is from Canada, and I've spoken with him before, but haven't had the pleasure of meeting him before. But he does work in this area. So let's move on to the topic of what we've learned about women with Rett syndrome, mostly from the natural history study, and some information that we've learned just from having done this for many years at the different sites, some of whom are on this call. And I'll just run through these. And I think there's something to be said for going through the points individually, and then we can talk about them if someone has a question at the end. But we've learned from the natural history studies that the weight actually increases after puberty, and that means that we tell parents this in clinic, we're going to push calories like mad to get your BMI above a target of 12 is our personal threshold here of what Dr. Percy and Susie, our dietitian, feel like is a healthy BMI. And we tell parents we're going to push like crazy to get you to that point. And then we've learned from looking at the data that after puberty, the weight really increases, and so we're going to start pulling back on some of those calories that we've been encouraging. Linear growth continues for about 2 years after puberty. And then we learn, just anecdotal, I wouldn't necessarily say it was statistically significant, but having had my ear to the ground, if you will, through social media, I know that weight maintenance or even adequate weight gain in adulthood can be a real problem. Whether or not these are girls or women rather who are not followed closely, often maybe they're in because of family health reasons, they're in long-term facilities that and maybe it's just an environmental reason, maybe it's because of the mechanics of chewing are difficult for whatever reason, maybe it's a sign of some insidious illness, but it is shocking at some points with some families I've spoken with about how small their adult daughters really are. Constipation and reflux don't miraculously go away in adulthood. Those continue and actually may be even more problematic in terms of treatment because of use of maybe long-term use of enemas and treatments or interventions that we wouldn't necessarily at this day and age recommend. Adequate fluids are always difficult. Intake of adequate fluids is a problem from the get-go for many of the girls. And there again, whether it's because of environmental changes or worsening swallowing issues, it certainly can be a problem, and as well as choking risks may even increase. We have talked a long time now about the incidence of gallbladder dysfunction, and I know at the time URSIF, now rettsyndrome.org, helped us with a paper survey of through the natural history study sites of gallbladder dysfunction, and I can say that that most of the time, the vast majority of the time, it's poor function. It's not a matter of gallstones oftentimes, although gallstones can be the culprit. It seems to be mostly poor function. And in that regard, the HIDA scan is the, at least at our institution, the study of record that we just go to help diagnose the function of the gallbladder. Most physicians want to start with an ultrasound just because it's the less invasive, and it may, in some small number, identify stone issue. But the HIDA scan has been most helpful in identifying a dysfunction. I can say personally it's often a battle unless the ejection fraction is just really in the toilet. It's very difficult sometimes to get physicians and surgeons to listen that a gallbladder function of ejection fraction of 20 is what's causing this change in behavior and appetite and obvious pain episodes. They won't listen, and we're very excited when the time comes to be able to show them the actual data of what we think is a higher incidence of gallbladder dysfunction, as a way to convince them that a bad gallbladder needs to come out. This is a slide that Susie, our dietitian, communicates with families and calculates when she sees our families. For those of you who don't know Susie, she's, from a dietary standpoint, or a dietitian standpoint, I should say, has probably seen more girls and women with Rett syndrome as a dietitian than anybody else in the U.S., certainly. So while these standards are just that, they're rather standards. She often has to manipulate these based on the individual, or some of them may be manipulated by subspecialists like endocrinologists or orthopedists or whomever, and it may vary with what the individual is going through at that point. She may push some things to the upper limits if the individual is facing surgery in terms of enhancing immunity and healing. But for the most part, we follow the guidelines pretty closely as set out by and published as the recommended daily requirements and recommendations. I highlighted these in red, though, as the ones that we focus on probably most in clinic. Calorie intake for obvious reasons. Calcium, it seems that these recommendations for both calcium and vitamin D change almost yearly, but somewhere in the neighborhood of 1,000 milligrams and even more after menopause. And then, of course, the vitamin D levels here seem to be a little bit lower, but than what Susie typically strives for. But I'll talk about that a little bit more in the next slide. And then we've decided, or I guess our practice philosophy now is to really ask how many cups a day of fluids is the individual getting, and she and Dr. Percy actually calculate how many cups they should be getting and make recommendations, particularly if there are multiple caregivers, to say, okay, she needs this much a day, fill up a bottle at the beginning of the day, and by the end of the day, the bottle should be empty if that's her total recommended day requirements or recommendations per day. Fiber is always an issue as well, and can be addressed either by diet or by supplements. And then the average BMI, and this is in typical individuals, adults, should be somewhere in the neighborhood of 21. As far as the vitamin D goes, we've started just recommending to get a serum concentration level, which we would like to be somewhere in the neighborhood of 50. And then sort of that helps Susie and Dr. Percy guide what their recommendations are going to be in light of the bone density issues. And if they really feel like they're out of their league, then we make a recommendation that they see either an orthopedist or an endocrinologist or someone who can give better guidance in that regard. Mental health, we feel like, is not something that oh, there's a typo on that. It's not mental health, it's mental health. Sorry about that, but it's not something that we're necessarily very good about taking a look at, but we do know just from observation that the women often seem less anxious, maybe a little calmer once they're out of that early, certainly beyond the regression years, and then again sometimes anxiety can rear its head again when they're going through puberty, certainly moodiness, if not anxiety. But the take-home message about mental health is that if there is crying, first look for a medical reason before you automatically go to, this is just behavior. And then if there is crying in the absence of a medical reason for that, then look for, whether or not it's depression that would perhaps be that would respond well to medications. And we do know that that environmental changes certainly can contribute to any mood changes in girls who have left maybe a school that they've dearly loved. Certainly the environment of being with other peers, and then moving in back home during the day with aging parents who may not be as interesting as they would like them to be. I should have mentioned that that we do treat anxiety with SSRIs here at this clinic, specifically with Lexapro is sort of our go-to medicine, and it does seem to help even out the mood swings and the anxiety that are often manifested in all ages. And then we ask ourselves, is the flat affect that we often see, sadness, or just part of the disease process where, everything just becomes sort of flat? And is that part of Parkinsonism? In general, EEGs may lose their epileptiform features. Seizure rates may decrease as they move out of their adolescence, and around that time that puberty may cause an increase in seizures. However, dystonias in adulthood certainly worsen. Rigidity increases as well, and the rigidity is oftentimes misdiagnosed as hypertonia, and stereotypic hand movements slow. Their stereotypies may almost go away, if not go away, in their third and fourth decades. Breathing patterns often improve as well. In terms of cardiac and prolonged QT intervals, cardiac function, about a quarter of deaths in individuals with Rett syndrome are sudden and unexplained, and we wonder if that's because of the prolonged or long to QT intervals. Mouse model work that was done out of the Newell lab at Baylor looked at beta blockers versus phenytoin, and in the mice, he demonstrated or proved that the phenytoin almost completely abolished arrhythmias, but in fact the breathing patterns in the mice worsened. And then propranolol or beta blocker really showed no benefit in terms of the arrhythmias in the mice. And then after that, again from the Newell lab, they did a retrospective analysis of the QT status before and after starting sodium channel blockers for seizures. And that was also done, looked at in using the natural history study data and cohort. And that retrospective analysis showed that the QT interval was significantly improved after individuals were started on sodium channel blockers for seizures. We still recommend EKGs on an annual basis, probably every 2 years would be okay, but would it be okay? It would be okay as long as the EKGs in between were normal. We say annually because it's easy to remember in the younger girls when they go in for their well-child visit with their pediatricians. But certainly it's not a one-and-done test. They need to continue to be screened for prolonged QT by EKGs because situations change. It's not a steady state necessarily, and certainly medications that can cause this also may have been added in the interim between EKGs. Some of this I've talked about, but talking about ortho and mobility, talked about the worsening dystonias, some of which may require Botox injections or baclofen to counteract. There's a general slowing of movements. Everything is slower. Like I talked about the stereotypies being slower, and ambulation often is slower. The girls, as women, are interested oftentimes in sitting more and not being as mobile. So it really takes someone some motivation to get them up and moving, and that's hard for parents who are in their 50s, 60s, and 70s, and maybe older, to want to go to the mall and walk around just to have a nice environment, controlled environment, temperature-wise, to walk around in. And so that's when it's nice if they can have some sort of companion, better if it's an age-matched companion that can get them out, the women out, and take them places so that they can be interested first and foremost, but ambulatory is just as important. I talked about the rigidity, which is often confused for hypertonia, and you have to explain the differences. Loss of therapies are common, and we were visiting in Colorado last week, and Tim Benke there brings out a very nice, he has a notebook of papers that he shows, journal papers that he shows to families to bring home the point that he's making, and he shows a particular graph that illustrated that clinical severity may increase in adulthood. And his point in talking about this in clinic is that because that's the natural history of the disorder, or is that a secondary effect of not having as many therapies? And his point was you really have to continue to keep physical therapy a priority, and that's difficult in the current environment because insurance companies don't want to pay for therapies in adult individuals. They're used to wanting, to do therapy if it's a broken hip, and you get a month's worth and then you're released and everything's all fixed. And I don't have an answer as to how we can make this happen other than just being loud proponents and advocates in this regard. And then, of course, the bone density issues that have plagued individuals with Rett syndrome continues in adulthood. There have been 2 survival studies, one that's been published and one that's in manuscript, both looking at natural history study data. One that was done pretty early on in the natural history study first round. We started enrolling in 2006 in this study by Kirby and others, and that was out of here at UAB, looked at in 2008, showed that at about age 52 there was a 50% survival, which is considerably longer than what was described by Rett early on. And then at this point, Tarquinio and others have written a manuscript that's in preparation that revisits this topic. And of course, parents are aging and therefore must be prepared for making provisions both to be able to keep the individual, their daughter, at home, or in the event that they're unable to do that, what's going to happen if they can't keep her at home. Is there another family member who would be willing and eager to have her, or is there another situation that has to be considered? And I think just like everything else with in life, if a controlled planning is better than being reactive under stress. And so I think it's not necessarily something that parents want to hear at the time that you make the diagnosis when they're 4 or 5, but as we talk about transitions, it's a natural thing to talk about. Have you thought? Are you planning? Are you, who have you identified as the person that would be your choice if you were not able to take care of her, even short term? I mean, if it's a single mother who has broken an arm, who's going to help her out with her adult daughter? So thinking back about being pediatricians caring for adults in Rett clinics, a much better, to me, way to think about this is us as leading the transition. And so our role is to, when we're thinking about just transitioning from our clinics, if it's necessary. So, and is it necessary? So you have to know and share from the get-go what your hospital's policy is for caring for adults. If you are jointly appointed at a children's hospital and an adult hospital, then does that make everything okay? Is your hospital willing to see them, allow you to see them as outpatients, but if they're inpatients, then that's a no-go? Are they allowed to come for clinic, but not for, for a study, but not to receive care? And so these are all things that you may think you know, but you may not. And some of us have been pretty surprised at double standards of our children's hospitals. In one regard, they don't bat an eye at continuing care for an adult with CF, but you, and I don't think they mean it to be mean. I just think that they understand CF because it's not a rare disease. They don't necessarily understand the implications of a woman who may be the size of a 12-year-old or a 14-year-old, but who may be 30. And so they don't understand that it may not be appropriate for them to be intubated by the team at the ER of the local hospital, adult hospital. But regardless, don't promise what's out of your control. And I think we all want to shelter and shield our families that we follow, and and we want to continue to care for them. I don't think there is a person on this call that doesn't feel that way, but there are some things, unless you're going to have clinic in your basement, that are out of your control. But you can establish right off the bat if you will be able to be, if you're willing to be available for consultation if the need arises. And I think that's something that's a very doable thing and something that we all do from time to time. And then regardless, or I should say not even regardless, I think I should say inevitably we become transition planners even for the pediatrician to adult primary care, because pediatricians also don't like to think about passing people off. They don't want to be perceived as not being caring, and they're not. That's not the case, but it may take someone from our clinic saying, being the facilitator, bringing up the difficult topic and telling families, and we do this. We try to start in their early teenage years or middle teenage years. Talk to your pediatrician and talk early and talk often about whether or not they are willing and their practice is willing to see you beyond a certain age. It's quite variable. Some families talk to us about, I called for her 18th year visit and couldn't even get an appointment, and we had no idea. But yesterday we spoke with someone in clinic, and they said, oh no, we've talked to our pediatrician. This particular child is 11, and the pediatrician is willing to see them until 26. The problem there in my mind is that practices change, practice policy changes, healthcare policy changes, and so you have to be willing to families have to be willing to revisit that at some interval so that they can make a control change. And so we can facilitate that by bringing it up and also advocating, being advocates for the families, even though we are not the pediatricians or the pediatric practices or the pediatric nurses. So these are a list of some what you might say are perceptions of the transition from pediatric care to adult care. I'd say that they're, misperceptions in many ways. Certainly the idea of if I ignore it, it will go away, as some of our families feel, is a misperception. I think that often families think that pediatricians and children's hospitals and Rett clinic are mean and heartless because they're making us leave. I think that's a real big misperception. I think that there is very good adult care, so good adult care is not lacking. Adult physicians can be gruff at times, so can some pediatricians, but I think that you just have to find a good fit, and we have to tell families that that if they don't get a good feeling from one physician, that they can certainly keep shopping until they find a good fit. And then, the old adage of adult physicians don't know anything about Rett syndrome. They're not interested in learning. And another side note may be, I'm tired of teaching. And so I get that, but that's where we can step in as advocates and help the adult physicians learn about Rett syndrome. This is actually taken straight with some edification from Facebook, which in many ways can be my nemesis, but it certainly is a good thing for the families. I'm going to read this. So this parent said, I have a major issue with pediatric neurologists who refuse to treat my daughter, and I've changed her name to Kim Kardashian, who is 34. I understand that their rules and their schooling is in pediatrics, but what do you do when your daughter has Rett syndrome, a pediatric disease, and when you take her to numerous adult doctors, they don't have a clue what to do? I actually had one ask me, what do you want me to do? I know Kim's body is 34, but she's 5 feet and under 100 pounds. An orthopedist even said the same thing. I don't know what to do with those tiny bones. And then this mother continued, I feel Kim, this is a strong statement to me, I feel Kim is not being able to receive the care she needs and deserves. And that made me sad. And this was sarcastic. Great news. The Cayenne, I said it wrong, Keanu West University Hospital is now opening a Rett clinic. They won't see Kim either. Oh, but for the research program they will. So a lot of frustration there, a lot of anger. They feel like they're being kicked out of their comfortable environment. They're tired of teaching about Rett syndrome. They definitely have the fear of the unknown, and they don't recognize the advantages of making that controlled transition. I used the example with this mother that I just quoted, and told her or suggested to her, if your pediatrician or your pediatric neurologist or your, fill in the blank, doesn't have privileges at the adult hospital and there is no transition ahead of time, then if she gets sick and has to be admitted, she has to go through the ER. And it's just a, pardon my phrase, a crapshoot who she gets. It's not going to be somebody that knows her. It's not going to be someone who knows you as a family unit or knows Rett syndrome and frankly doesn't have time at that point to learn. So if we talk through while these controlled transitions are best, then we've helped hopefully that family understand that it's not just being mean or being heavy-handed, that there are reasons for these transitions. And part of the reasons is that it's adult medicine, regardless in many ways because of her size, they're regarded as children. But if you go back and think about the healthcare calendar or schedule of events that I showed earlier, there are things that you wouldn't think to do in children. And so adult physicians are best to treat, are the best at treating adults. And so we have to do some of that teaching on the front end. And insurance is another unrecognized advantage. A few years ago, Dr. Percy agreed for various reasons to provide care refills for an adult physician, and so he said, yes, we'll fill this birth control pill that she's getting for menstrual management until you can find an adult person. The mother had just passed away. The father was trying to do the best he could do, and so I, in my naivete, called in this prescription for 1 month of birth control pills and got into the whole turmoil with Medicare and getting it covered by Medicare. And it was a nightmare that I was not knowledgeable about how to circumvent that or to navigate that. And so it's not that we don't want to, we just don't know the buzzwords, we don't know the ways to do it best. And so it really has to happen. And so we can smooth the way, and we smooth the way in a number of, and probably the number one way we can smooth the way is to use transition teams if we've got, and I didn't even put that here because most of us don't have, I don't think necessarily, access to a transition care team. And these are teams who that's their sole existence of functioning between the children's hospital world and the adult hospital world, and trying to make a transition between the two worlds. And that planning should begin in an individual with a complicated situation at least by age 16, maybe before even to start to talk. And it should be discussed at each visit and asked about what progress has been made. If you can provide suggestions about good adult physicians or ones that you maybe went to school with, who went into adult care, or that that parents tell you about when they come to clinic. I have sort of a running log of adult physicians and physicians in other states and other even other towns in Alabama. And so that if someone asks, I might have someone on my list that has been a compassionate and effective physician. Present it as a positive move. I think that that's first and foremost, and remind them that new physicians don't have to know Rett syndrome, but they do have to be good listeners and willing learners. And then we have to be willing to be that bridge to pick up the phone and call physicians if they've invited that communication, or sharing phone numbers. Yes, tell him to call me or her to call me. I'm happy to talk, because that may smooth the way. And then also tell the families that one bad apple doesn't spoil the whole barrel, that there are good and bad in every walk of life, whether we're talking about mechanics or physicians or parents for that matter. We can build a database. I've talked about that, of adult practitioners. And then I think we have to be good about providing comprehensive medical records. And what I mean by comprehensive, I mean good notes at the end, before a transition happens, with outlining things that would be helpful for someone who's never heard of Rett syndrome. The transition team approach, there, as I talked about, there's some overlap of time, either in person as a team, or virtual by phone, or by things just like GoToMeeting. Being available for consultation after handoff, taking Rett syndrome out of the equation, and being compassionate, because as the quote that I showed you, that was not someone who was just railing because she was mad. She was worried, and she was upset, and she was frustrated because she wants to do the best for her daughter, and that's we have to remember that. Of course, adult care comes in all shapes and sizes. From the small town where there may be internists or family practitioners or nurse practitioners and subspecialists, but also one thing that we've found to be quite successful, but that might be more associated with a big city medical center kind of access, is the med-peds physician, those who have been cross-trained as internists, so they know the adult side, but also are educated and trained as pediatricians, so they know, they understand developmental disorders. They're not, scared to death of someone who is nonverbal or who maybe can't walk into their office. And so that's been a very good alternative or option for us here in Birmingham. I've found because we're lucky enough to see people from all over, if we're talking, for instance, from someone who's from Tennessee who needed a physician, and I went online and found out that Vanderbilt also has a med-peds practice affiliated with the adult and the children's hospital there, and so you give the families the physician finder number, and you tell them that you would like to be connected with the med-peds practice, and they've been very pleased so far. So that's a good alternative, I believe. I'm going to stop here. Since I'm not an expert on transition teams, I would be very interested in hearing about your experiences with those, any advice or pitfalls, or any questions that you might have. Thanks.
Thank you, Jane.
Judy?
Yeah, hi. Thank you.
I do know that Baylor is one place that uses transition teams. Is that something that I was glad that you were on the call for a number of reasons, but I was wondering if you have had any experience with transition teams.
Yes, as a matter of fact, a number of years ago, the hospital began an initiative with transitioning general pediatric care to adult care. But more recently, since that time, we have developed lists with particularly the highlight subspecialties, pulmonary, PM&R, orthopedics that do see Rett syndrome quite a bit. And I've developed a list, and it's still a project in the works, but that I hand out to families of our maturing ladies of within our area, adult care practitioners who are even interested and somewhat knowledgeable. We're teaching them. That's going to be the next phase, of course, of what we're doing is teaching them so that we don't send them off to someone who's never heard of Rett. But we have a handout now that we can give for the various specialties of some practitioners, phone numbers, addresses, that they can use to start searching for who can best do the next level of their child's care. We will continue to see them in the Rett Center here at Texas Children's, but of course you go back to the admission to the hospital issues, which has become quite problematic.
Right.
Yes, Jane, this is Art Bysang up at Gillette.
Yes.
And we're very lucky up here in that we have a clinic for adults with disabilities called the Lifetime Clinic. And so I work with a couple of my, Rob Wagner, who's a family practice doctor, who will see a lot of the patients as they get older. And we will admit kids here till age 26, and then we have them go to Regions Hospital, which is physically located in the same area. And we're very fortunate because we've been training med-peds doctors. I have been for 25 years. So a lot of my old residents are over there as hospitalists. And so I can twist arms if I have to.
That's why I was laughing. I thought I could just see it.
Yeah. And you know, what's nice is I have privileges there, as do a couple of our adult providers. So we provide kind of a liaison service because adult hospitals, as we all know, have a very different focus, and they don't have the family focus we're used to in pediatrics. And I think a lot of our families get turned off by that lack of attention to the family that is second nature to pediatric hospitals.
Exactly.
So I think that's really helped. We're very lucky in that we have that close proximity, and that's helped us. The other issues that have really been nice with our transitional clinic is we really have some social workers who are expert at helping with that transition from school, which is one of the very big transitions. And then later on in life, it's a place where we're able to connect our patients with the adult providers we need.
Mm-hmm.
So,
Mm-hmm. So how did you bridge that or reach out, and I'm saying you in the collective way, to the Regions Hospital? Is that something that the transition team built that relationship, or?
It's we're fortunate we have a lot of personal relationships.
Okay.
So we start by talking to individuals that we know have an interest, and have those individuals present the idea to their group of, you know, how can we take care of these kids with disabilities? Mm-hmm. Is there a special part of the hospital, meaning Regions Hospital, where kids with disabilities can be housed when they need to be hospitalized, so that the group of nurses and social workers in the adult hospital have more experience working in more of the same way we do in the peds hospital.
Right, right.
And it's a work in progress, but it's been fairly successful.
Yeah, that seems ideal in many ways. We've been more like having our heads in the sand. Well, for years we didn't worry about it. We just thought, because it was never an issue, and whether it's because of some litigious or liability reason, or is it because of financial reasons, but it's only been lately that there's been pushback here about admitting to the Children's Hospital, and it's really it's really been causing problems. Every time we have to admit someone who is an adult and maybe a in her late 20s adult, maybe early 30s, we sort of hold our breath thinking it's going to be an issue and do a collective phew when we swipe our foreheads when we know we've dodged the bullet one more time.
So we're very lucky because it's 150 feet, and I can walk over and meet with the doctors and the families that I know well, and that that physical presence can make a real difference in a tense situation.
Right. And the problem then is, Minnesota's a big state too, so what do you do? And then your catchment area is more than just Minnesota, so what do you do with maybe even people who have out-of-state Medicaid, or, that's where it really gets to be a problem, I think, because we all, being the few places who are, Rett specialists and Rett centers, we see people from all over. I know everyone on this call does. And so that's where it gets sketchy, is when they're out in the community and you have less control.
Yeah, absolutely right. That's where we rely on the telephone.
Yeah.
And families begging us to call the doctor. And I think, as you said, there's a lot of very talented adult doctors who are willing to manage our patients if we are available as a resource for some of those Rett-specific issues.
Right. On standby, if you will.
Yeah.
I worry less about those physicians. I worry about the ones who won't reach out for help.
Mm-hmm.
I had a bullet point on this slide and I took it out about that they have to be good listeners and have small egos, and I decided that might be a little too forceful, so I took it out. That's in essence, that's true, is that they have to be willing. We're always willing to call them, or we prefer for the physician to call us just because we feel like they'll be more receptive if they're picking up the phone. But if need be, Dr. Percy is called on the other end, and they have to be willing to listen.
Yeah. Well, they better listen to Dr. Percy.
Heaven knows I do.
Yeah. Another area that we should maybe talk about at another time is birth control, and a little more in depth with bone health. And what are we starting early that's going to affect the women as they get older?
Yep. Our general recommendations are against Depo-Provera, but even just the basic combination estrogen progesterone birth control pills may have some effect as well, and then whether or not they can be used in individuals who are not ambulatory, opens a whole nother can of worms. That's a talk in and of itself, and certainly one that I know a little bit more about it, but not a ton.
We've been moving towards the newer version of Norplant, the Implanon.
Uh-huh.
No very little estrogen, and I'm not sure if that's the right thing to do, but it seems to make sense.
Yeah.
I'm always looking for someone with more expertise in that area.
It's Patrick McLeod from Canada logging back on. We had a disconnect here. Just to change the topic a tiny bit, a couple of comments. One thing that I've been impressed with is the fact that most of us ascertain these individuals when they're quite young, and we take a detailed family history. But I think we need to go back 20 years later and update the family history, because in that 20 years, familial diseases have come to the forefront. I'm thinking of 2 families that had colon cancer that took the lives of one of the girls for lack of an awareness of the genetic contribution to colon cancer. The second thing
excellent point.
The second thing we've done here in Canada is to try and cite our 4 clinics in centers that have a rehabilitation hospital or a rehabilitation center that takes all comers in the sense of children as well as adults. So that applies to Edmonton and now to Bloorview in Toronto. The one pediatric hospital is in Ottawa, and they continue to see adults in a pediatric setting. But there are restrictions on that as well.
That's an excellent idea, and it took some forethought on somebody's part to do that.
Well, it's just the reality of the fact that I think there are a whole bunch of policy issues that relate to pediatricians seeing children above a certain age. It's a fee-for-service based system, and they're not covered. And also, I think the hospital, for example, a pediatric hospital gets government support for a certain type of clientele, and adults don't qualify in a pediatric hospital, so that's why they are discouraging having clinics in pediatric hospitals. For example, Sick Kids in Toronto had that particular problem brought forward, so that's why it's now gone over to a comprehensive care team at Bloorview.
Well, it's Peter Humphreys from Ottawa. Just to that, the only reason that we were allowed to have to see adults in our clinic at the Children's Hospital is because of the geographic situation. The only genetics department in Ottawa is located at the Children's Hospital. They also see adults, and so it wasn't too difficult to persuade the administration to allow us to see adults in the Rett clinic here. However, as has been pointed out before, any further investigations or any admissions have to take place in the nearby adult hospitals.
Right.
This is Saj calling, and I'm just listening on, and I just want to share a few thoughts, and hadn't heard anyone talk about the fact that they might consult with the rehabilitation facilities or clinics that you might have in your centers. We've certainly created kind of a transition with the adult rehab docs, and many of them are more than willing to take care of children with Rett syndrome or young women with Rett syndrome, mainly because they do deal with neurological disabilities, etc. So in our clinics, we can children and young women till they're 21 years of age. That goes also for genetics and metabolic clinics, because there's no genetics and metabolic clinics for adults. So I guess when you're talking about transition teams, you most probably are dealing with people that are working in rehab facilities. Is that correct?
Judy, can you comment on the composition of the transition team at Baylor? Don't want to put you on the spot, but
no, actually, I started this whole program by connecting with our pediatric subspecialists and finding out who they recognized as quality practitioners that would be good to approach. And then I've contacted office managers and been pleasantly surprised at some of the responses I've had. In particular, with Baylor being a teaching hospital, of course, one PM&R physician in particular did part of his training at Children's. He's very interested in movement disorders and has embraced becoming the top of my list of the PM&R specialists for adults.
But I thought that Baylor had something called a transition team.
They
that
did.
Actually.
Go ahead.
No, that actually, sort of like what Soj was saying, has reaches out and bridges the across all subspecialties and primary care, for not just for developmental delay, but those with CF or anyone who has a childhood chronic or lifelong disorder.
They do, but it's for general care. I don't believe they go into the subspecialties.
Oh.
They do GYN, they do, PCP work.
Uh-huh.
But I can look further into it and get back with you, but I don't believe they have the subspecialties that I've been able to identify.
I'm going to take this opportunity just to log off because I have patients this afternoon. That was a great presentation. I really appreciate it, and I look forward to having the slides.
Well, thank you, Pat. It was good to talk with you again.
Thank you again. Bye-bye.
Bye. Well, that's all I have. I know everyone has things has things to do, as Pat did, and the others that had to leave. So, Paige, did you have something you wanted to announce or talk about?
Yeah, just real quick in closing, I want to thank you, Jane, so much for bringing this discussion to conversation. I know that it's an issue in the U.S. and it's talking to foundations around the world. It's a problem regardless of what healthcare system that you're working in. It's the nature of Rett syndrome and primarily being a pediatric disease. And, as we've talked, girls and women living longer, and the more years that we have of diagnosing Rett syndrome, we're hearing more and more families experiencing the concern about transition and living in the adult world. And most are making it okay, but I am really encouraged by hearing about the emergence of more med-peds physicians and transition clinics, and I'm hoping that I can work with somebody in this network to perhaps publish something, because I don't think that the average family is aware of this as a resource. And perhaps if we can encourage more grassroots activity on behalf of parents, asking their physicians and hospitals to develop that, perhaps we can impact this experience for families. So I really, really appreciate you, Jane, helping us focus on that specific period of transition. And I would really love to see something authored to get the more awareness about the positive side of transition and educating other physicians, clinicians, and families about why it's a good thing and an important thing. Okay, so thank you very much, and especially with you battling a cold, you did an excellent job with your slides and with talking, and I hope you feel better. I think in the interest of time and it being Friday afternoon, we should conclude our call. I just wanted to make an announcement about conference. I've had a lot of folks ask about the family conference this year for RettSyndrome.org. We've tried to do a lot of communications that it will be a virtual conference in June. Just as we're using GoToMeeting for our clinician network calls, we're finding a lot of success in that we're reaching a lot of families by doing more online webinars than we can ever reach by having families have the expense for traveling to conference. And so we're alternating every other year now with, this will be the first year that we'll do a virtual conference in the month of June. And next year in 2016, we'll go back to our traditional on-the-ground conference in Chicago in 2016. The reason I'm highlighting this is because you can expect an email from me in the next few days with an invitation to everyone on this call to consider submitting a proposal for a talk that you might like to deliver during that virtual week in June. Since we won't be bound by travel schedules or travel costs and budget, it really opens up the opportunity for me to invite all of you to present on topics that are really of interest to you and that you know are important to families. So look for that email, and I really would appreciate you taking the initiative to let me know what you'd like to present to families and what you think are important topics. And you would be my first line of requests. So usually when conference time comes around, I go out and I approach each of you individually based on our travel expense and budget and location to present. And I'm really excited to not be restricted by those means this year. So look for that email, and I invite everyone to please let me know what you'd like to have as the next topic for our call in May, right? So we're third Friday of every other month for these network calls. I heard a consideration to do a deeper dive on, focusing on adolescence and adulthood and managing menstruation and bone density. And Jane, if you'd like to be up to that again, I'll let you tell me if that works with your schedule, but I'll circulate a request for topics. Okay,
yeah,
so
I think Alan thinks he's talking about the natural history study.
That's what I'm hoping. That's what I'm hoping. I'm hoping that you'll be prepared and we'll be at a place where there'll be some really good details to share. Mm-hmm. Does that still look to be on track for?
I think it's something that is on his calendar. Whether or not it might be better, a later topic or later time, a topic for a later time, when he does have more information. I don't know. We'll
see that when we'll see when we get there. Yeah. Okay, great. Well, thank you, everybody. I hope you have a wonderful weekend and a great afternoon. I hope this has given you a lot of thought for what you're doing in your own clinic, and will just spark ongoing conversations, because this is a really important topic to our families, and there's just a growing number of families that are dealing with this, and I'm so grateful for all of you for helping. So thank you, Jane. Thank you, everybody, for a great conversation and discussion, and we will talk to you again in May.
Bye-bye, guys.
Bye.
Okay, thanks. Bye-bye.